All right, well, why don't we get started? It's 8 o'clock. I want to welcome everyone to the Department of Medicine Grand Rounds. And to kick off today's medical Grand Rounds, Dr. Nizar Jajor, who is our esteemed Division Chief of Pulmonary, Critical Care, and Allergy, will be making the introductions. Dr. Jajor.
Thank you very much, Dr. Schnapp. Good morning, everyone, and thank you very much for joining us for another exciting Department of Medicine Grand Rounds. This morning, it's my great pleasure to introduce my colleague and friend, Dr. Ravi Viswanathan, who did his undergraduate training at the University of Missouri and medical school at Rush Presbyterian in Chicago. Then we were lucky that he chose UW-Madison for his medicine residency and continued on to joining our Allergy and Immunology Fellowship, graduating in 2012. After his graduation, we were again lucky to convince him to stay here with us here on the faculty, joining us as an assistant professor and taking over the clinical practice of Dr. William Bussey, who at that time had retired from clinical practice. Ravi currently staffs a general allergy clinic and has started a drug challenge clinic for patients with suspected or presumed allergy to drugs. In addition, he partners with Dr. Lauren Denlinger in the Severe Asthma Clinic. It's a joint allergy and pulmonary evaluation for patients with difficult to manage asthma. Ravi is actively involved in medical student education, and he also serves as a principal investigator on an investigator-initiated research study on Omelism in idiopathic angioedema. Dr. Viswanathan has authored 15 papers and book chapters, and his research interests include urticaria, angioedema, drug allergy, and mast cell disorders. This morning, Dr. Viswanathan will speak to us about Mast Cell Activation Syndrome, a tale of diagnostic and therapeutic dilemmas. We're excited to have Dr. Ravi Viswanathan tell us the story. Thank you very much, Ravi.
Thank you, Dr. Jajor, for that wonderful introduction and welcome. And again, good morning, everybody. Thank you again for being here this morning and being able to give me an opportunity to talk to you guys about a topic that is emerging and evolving within our field, particularly with regards to the Mast Cell Activation Syndrome. So I'll be spending the time talking about that, and especially with some of the diagnostic and therapeutic dilemmas that we've faced with this. So I hope everybody got the code for the CME for this Grand Rounds. I've got one disclosure that I wanted to mention, and that particular disclosure and my involvement with the study should not have any impact with regards to the content of my presentation today. I will be talking about one investigational drug usage, particularly with Omelism in Mast Cell Activation Syndrome, as it is not FDA approved at this point. So my learning objectives for you all today is to first try to provide a brief recollection, possibly from medical school or later on, about mast cell biology and function, and then to turn the page and provide a little bit more of an overview and get an appreciation for the current definition as well as the evolving classification regarding mast cell activation syndrome, as well as the epidemiology that seems to surround this at this point. And then we'll spend a little bit more time talking about the current available diagnostic criteria and some of the biomarkers that we have used in making this diagnosis, as well as the potential difficulties that we have faced with those markers. And then finally, we'll spend some time talking about the therapeutics that are available for managing this particular condition as well. So I'll start off with a case. This is actually a patient of mine who I continue to follow. It's a 51-year-old female presenting to our clinic for a second opinion. So it's actually previously established with an allergist with complaints of fatigue, dizziness, lightheadedness, headache, imbalance, flushing, hives, abdominal pain, throat clearing, syncopal episodes. So she's experienced breathing difficulties on numerous occasions with these other symptoms as well, requiring albuterol, and has been treated multiple times through the emergency room for presumed anaphylactic episodes with fluids, steroids, antihistamines, and epinephrine, all with good response. She reports a wide range of triggers that seem to set off these episodes, including foods, alcohol, heat, cold, environmental scents and chemicals, as well as contrast agents. She is planning on, in fact, when she was coming to see us, to see Mayo Clinic for a third opinion as well. She's unfortunately had a poor appetite and has had a nearly 100-pound weight loss over the past 6 months. So I want you guys to kind of keep in mind this particular scenario, as this is fairly typical of patients that we see who are coming to our clinic to get an evaluation, either with a presumed diagnosis or for a suspicion of this condition. And I'll try to overlay the information that I'm presenting to you guys with this case periodically throughout the presentation as well. So let's start off a little bit about talking about mast cell biology and function. It was first discovered by Paul Ehrlich in the 1870s. The origin and structure for this particular molecule is that it's a hematopoietic stem cell of the myeloid lineage with cell surface markers, particularly CD34 and CD117, otherwise known as c-KIT. And it typically exits the marrow in an immature state and then goes to the tissue to undergo maturation. Now, historically, we've looked at mast cells as playing an important role in more host defense mechanisms against a variety of pathogens, particularly parasites and certain helminths. But more importantly, and they're currently well known for their implication in allergic reactions and atopic disease. As I mentioned earlier, the distribution for these mast cells is actually fairly wide, so it actually can be found in virtually any connective tissue at the mucosal surfaces. It's typically not the most dominant cell that we see there, but can be seen virtually in any tissue. How do they affect their function? They are typically going to be releasing a whole host of mediators that then serve to implicate the functions of this particular cell type. They contain a large number of granules that release both preformed mediators as well as mediators that are newly synthesized and then rapidly released. Those include histamine, leukotrienes, prostaglandins, a variety of proteoglycans like heparin, a variety of proteases, as well as a whole host of cytokines. So here's kind of a schematic representation of a mast cell that essentially, as you can see, is peppered with a whole host of receptors. And the two sort of important concepts that I want you guys to take out of this particular slide is that there is an immunologic means of activation for this mast cell, which uses the high affinity IgE receptor to which IgE binds. And then you have an antigen that then binds to these IgE molecules, cross-linking occurring, and then degranulation of the cell to trigger the inflammatory cascade. Now, you can also have what we call non-immunologic activation or direct activation of the mast cells using other receptors, including toll-like receptors and the newly recognized MRGPRX2 receptor, whereby a variety of other compounds can directly activate the cell itself without using an antigen antibody-based mechanism. So classically, when we look at radiocontrast media or vancomycin resulting in those symptoms, that's how that particular process occurs. So with this background in mind, what do we mean by mast cell activation syndrome? What is the definition and why did it come about in the first place? So I'll start off by giving you a bit of a definition as it stands right now in our field. So mast cell activation syndrome basically is sort of a broad definition or a term that's used to describe a variety of disorders that have diverse causes and typically resulting in multi-organ, multi-system symptoms, typically as a result of release of mediators that I showed earlier from these mast cells. The whole diagnosis originally came about because we had fairly well-established mast cell-based disorders such as acute urticaria or chronic urticaria, as well as systemic mastocytosis that had clear diagnostic criteria established. However, what we started to see is where we had patients who were not quite fitting some of these established mast cell-based disorders. So some of our experts in the field decided, well, does there have to be a sandwiched diagnosis that we need to coin that would encompass these people that we can't firmly place in these existing mast cell-based conditions? So hence, this particular term was originally coined as sort of a diagnosis that could meet these set of patients. However, what's actually happened is that this is sort of morphed into kind of an umbrella terminology and a diagnosis such that it actually encompasses all of these disorders and more as well. So as it currently stands, the way we look at this is that mast cell activation syndrome sort of has a triforked classification whereby it gets divvied up into a primary mast cell activation syndrome process that includes the systemic mastocytosis and a variant of the systemic mastocytosis called monoclonal mast cell activation. So these are all entities that typically have some sort of a clonal mechanism or a bone marrow-based process that's driving this, which is by far the most common of what we typically see. Examples of that include allergic rhinitis, asthma, atopic dermatitis, allergic reaction, anaphylaxis, or examples where we see mast cell activation occurring as part of that other disorder. And then you have idiopathic mast cell activation, where there is an exaggerated response and activation of mast cells, but a clonality is not necessarily present with those processes. So what about some epidemiology and some facts about mast cell activation syndrome? Primary mast cell activation syndrome typically is rare. So it has an occurrence or a prevalence of about 1 in 10,000 to 20,000. Secondary is by far the most common, about 10 to 30% of the population. So we're talking about millions of people potentially having this condition. I listed a couple of examples of that over here. Idiopathic, we don't really truly know about the prevalence. A couple of other important facts to know about mast cell is that it can be a very normal and physiologic response to a particular intrinsic or extrinsic trigger. So it doesn't have to be pathologic. However, I'm here talking about this, so there certainly is a pathologic abnormality about this as well. So you can't see this problem as part of an abnormal productive process, as well as an abnormal responsive or an exaggerated response mechanism as well. And I'll talk about each of these in just a little bit. So what do our patients who come to our clinic typically present with? So this is typically what we tend to hear from our patients. So this elaborate sort of schema or a diagram that I'm showing here essentially is pinpointing or showing us a wide range of multiple organ system-based symptoms that we typically see our patients presenting with. So there's typically not a focality to a lot of their complaints when they're coming and talking to us. Prominently, we see a lot of skin-based findings. This is by far the most common of the symptoms that we hear from patients. It includes flushing, itching, hives, swelling. You also see prominent non-specific digestive symptoms, cramping, abdominal pain, nausea or vomiting. There are respiratory complaints, including both upper airway and lower airway complaints. And there are also concerning cardiovascular symptoms. So you can have syncopal episodes or pre-syncope and hypotensive episodes. And then there are also neurologic consequences that patients present with, lack of ability to focus and cognitive impairment that they often describe as feeling a very foggy sensation in being able to concentrate and do their activities. So overall, a picture where when you hear the symptoms from their patients, it's just not entirely clear what are we dealing with in terms of where do we need to focus and how do we need to consider our diagnostic or therapeutic workup. What about the triggers? What's causing all of these episodes and symptoms? So here's a listing that I put up of a variety of triggers that patients report to us. Some of the most prominent symptoms we hear from patients are heat, alcohol, and a variety of medications. Particularly, we talk about antibiotics, particularly vancomycin, non-steroidal anti-inflammatory medications, narcotics, neuromuscular blocking agents. And then we also see contrast agents. Typically, it's iodinated contrast media agents, but you can see gadolinium-based reactions as well. Any kind of stressor to the body, whether it be a surgery or some other invasive procedure, can also unfortunately trigger some of these episodes. And then another important one to consider is that mast cell activation syndrome can be sort of an insidious way in which a bee sting reaction can present itself as well. So we just want to kind of keep a lot of these triggers in mind when we think about what might be driving their episodes. So these may be things that our patients are telling us about. What does that then lead to? It unfortunately then leads to a very broad differential diagnosis. Now, I've listed sort of the top 8 differential diagnoses that I pay a lot more attention to or keep in my forefront. However, if you did any kind of review paper analysis on this particular topic, you will basically find literally 1.5 pages to 2 pages of differential diagnosis for this particular condition. So having said that, I think the key ones that we want to sort of keep in mind with regards to what else do we need to be considering, include thyroid dysfunction, the drug-based reaction. So are we really dealing with the true drug reaction, or is a mast cell activation syndrome going on in the background? Various forms of angioedema can potentially result in these symptoms. Various neuroendocrine tumors and malignancies, carcinoid and pheochromocytoma. Adrenal issues are some things that we do want to consider. We obviously want to keep in mind and pay a lot of attention to whether those secondary causes that I mentioned, atopic disease, allergic reactions, are playing a key role. Is that a good explanation for what's going on with a patient's symptom profile? I did include this last entity called hereditary alpha-tryptosemia, which is starting to gain a little bit more notoriety and attention within our field. And I'll be talking a little bit about that down the road as well, where you can see an elevated baseline tryptase level as part of this condition as well. So these are things that we want to consider. Then what's the problem here? What's the dilemma that we might be facing given this broad set of symptom presentation, trigger presentation leading to a broad differential diagnosis? Well, as I said earlier, so the symptoms are so vague, diffuse, broad, and heterogeneous that we're talking about a very broad differential diagnosis. As a consequence of that, most of our patients are having to sort of navigate the healthcare system through many doctors. So lots of specialists and going through various people to eventually come up with a diagnosis, if they come up with a diagnosis at all. So what that then leads to is a difficulty and a delay in making a diagnosis, for this particular patient. So oftentimes they're going through neurology specialties, cardiology, dermatology, and then eventually coming to an allergist as well. So you can end up taking months to years to end up making this diagnosis. And as I mentioned earlier, the number of specialists that often are involved, are participating in the care of some of these patients is fairly high. So there was a survey that was done of mast cell activation syndrome patients, and when they were asked about how many specialists had you visited, they had mentioned a median of at least 3, with at least half of those people stating a number of about 6 physicians that they have seen to make this diagnosis. So consequently, not an easy process, and a very frustrating sort of travel and navigation through the healthcare system for patients with this condition. Another thing to kind of consider, and I mentioned this a little bit earlier as well, there are other established, atopic diseases and mast cell-based disorders whereby, that might be able to explain, some of the symptoms. But the question is that enough? Is an acute or a chronic urticaria with angioedema a sufficient explanation for the symptoms of the patient, especially if they are skin dominant, or do we need to be considering a more broader differential like mast cell activation syndrome? So then what do we have to help us make this diagnosis? Do we have some sort of a criteria that's available? And the good news is that we do now. And that criteria is what we call an expert opinion consensus criteria. It really consists of 3 sub-criteria, with the first criteria essentially referring to clinical signs and symptoms of mast cell activation that are severe, recurrent, and episodic in nature, and typically presenting, in the way of anaphylaxis. I highlighted a few terms here in red because the original definition and this particular criteria only included generic signs and symptoms of mast cell activation. And then they've gone through a few iterations and changes where they've needed to now include these particular terms to qualify, what we mean by a severity of these symptoms, which then helps to isolate the people that truly have this particular condition. So then criteria B is where there is a clinically significant elevation in a mast cell specific biomarker that goes along with criteria A. So you have to have both of these present as well and correlate with each other. And then criteria C has more to do with a therapeutic response. So we want to be able to see at least a minimum of 50% response in their symptoms when we target them with appropriate mast cell-directed therapy. So you have to have all three criteria to make this diagnosis. So if we have consensus criteria and we have other criteria for other established mast cell disorders, then again, where's the dilemma? What's the problem, in being able to manage these patients? So as I mentioned again, despite having this, there is a fair degree of overlap between secondary mast cell disorders and primary mast cell disorders. So we do need to be able to keep that in mind to be able to clearly say, are we dealing with the primary or an idiopathic process compared to a secondary process? The consensus criteria that we have right now is largely based on expert opinion. It does not have as much of a robust validation, and so therefore it sort of lends itself to a bit of both over and underdiagnosis of this particular condition. So we do need to kind of keep that in mind. The other problem that we often face with this is sort of a lack of familiarity and a comfort with this particular criteria itself, as well as the biomarkers that are used for this. So even though these are published, there are quite a few providers, including specialists within our field, that simply are not familiar with it, or are uncomfortable with ordering some of these biomarkers and being able to interpret that. And so therefore, what ends up happening is that a lot of these patients end up getting isolated, or sequestered to large tertiary care centers or academic centers for a particular diagnosis. Again, delaying that diagnosis overall. And finally, there has been also some concern about where alternate criteria have been put forth by some specialists and practitioners, and that's led to some added confusion, both among providers as well as among patients as well. So then what do we hear, and what do our experts tell us in terms of when should we be considering this particular diagnosis? So here's kind of a verbatim set of 8 questions that I pulled from one of our experts, Dr. Peter Valentin, Chem Aiken, who published in the Journal of Allergy and Clinical Immunology last year, looking at these 8 questions as a way for patients to ask themselves, after they've even been given a presumed diagnosis of mast cell activation syndrome, or there's a suspicion of this particular condition. And these 8 questions largely reflect the consensus criteria that I just laid out. So, and if the answer is in the affirmative for a majority of these questions, then you are more likely to be able to say that this condition is likely, and therefore we can proceed ahead with appropriate diagnostic and therapeutic strategies for that. When do I consider mast cell activation syndrome? So when there is a severe recurrent or single episode of anaphylaxis, that makes me want to think about this particular condition. Multiple drug allergies with IgE-based symptoms, not just adverse reactions or intolerance or sensitivity symptoms, but rather IgE-based symptoms. When there's also multiple generic allergies, we're talking about foods, lots of contact allergies, drugs included, again, all resulting in systemic IgE-based symptoms. When there's a big conglomerate of that that's going on, that also makes me want to consider this in the background. And another important consideration that I'd mentioned earlier is when there's a severe bee sting allergy reaction, I do end up looking at this as a possibility. So I want to stress the point that, I say consider mast cell activation syndrome, not to say that just because I see these scenarios that it definitely merits an evaluation, or that it is definitive for this condition as well. So let's back up to our case and then look at our patient. I highlighted in red with regards to the various symptoms that she has presented with to us, including these multiple organ system symptoms involving the GI tract, the skin, from a cardiovascular standpoint, getting a presumed diagnosis of anaphylaxis on more than one occasion, leading to a response to therapy with a variety of medications given through the emergency room, and having a wide variety of triggers. So if you look at this presentation, and this is a verbatim scenario that I've taken for one of my patients, so you're able to fairly well overlay with what we have typically seen and is well represented in the literature with regards to how mast cell activation syndrome presents. So at this point, when we look at this particular case, we find that this particular patient is able to meet criteria A and is able to meet criteria C. So the hanging chat in this particular one might be the criteria B. So hold on to that thought, and I will give you guys more in just a bit. What about those biomarkers, that I've been talking about? So there are 4 biomarkers that we typically use to make this diagnosis or to help aid in this diagnosis. The first one is tryptase. This is by far the most specific for mast cell activation, as well as probably the most widely used and the best in terms of time-tested marker for this. It's generally fairly reliably elevated with a variety of allergic reactions and mast cell entities as well. We also think about N-methylhistamine, as well as a prostaglandin marker called 11-beta prostaglandin F2 alpha, and then a 4th urinary marker called leukotriene E4. And I listed a few kind of features about each of these particular markers themselves. And so N-methylhistamine happens to be the one that's typically the least elevated so far in what we've seen in the literature, with the prostaglandin marker typically being the most commonly elevated marker. A couple of important points about these 2 markers is that assessing them may help with therapy to some extent. The presence of the prostaglandin marker has been shown to possibly have some impact with a positive response to aspirin therapy, particularly when an NSAID in an allergy is not found in that particular case. An elevated leukotriene marker can help with using a leukotriene modifier as a possible therapy for that condition as well. Couple of points to make about these biomarkers is that you usually need to do at least 2 measurements, one at baseline and typically another one with a flare. And you want to be able to look at and see whether there is a meaningful, clinically significant elevation in those markers from a baseline to a flare. So unfortunately, a problem with this is that we have that particular marker or criteria or what's considered a clinically significant elevation fairly well established for tryptase, but unfortunately for these urine-based markers, they are not as well established. So we've got some tools, to help us, in our toolbox, to make this diagnosis, but there's still some imperfections, that we have to contend with in this. So I wanted to quickly mention, one study that sort of highlighted that importance of needing to look at possibly using multiple biomarkers to help make this diagnosis. So this is a study that was done at Mayo about 5 years ago or so. It was a retrospective study looking at about 25 patients with mast cell activation syndrome. Again, you'll find that a majority of studies that are published, are going to be small n, just because the rarity of some of these conditions that we're dealing with, when we're talking about, primary versus idiopathic mast cell activation. So again, 25 patients who had MCAS, what did they find? What they basically found was that, every one of these patients, when we measured all 4 markers, had at least one biomarker that was elevated. So getting an assessment of all of these markers helps to capture a broader range of people that could possibly have this condition. And then they also found that the most commonly elevated biomarker was the prostaglandin F2 alpha marker, and that also correlated fairly well with symptoms. In this particular study, they also took about 9 patients as a subset and treated them with aspirin, and found that the majority of those patients had both an improvement in symptoms as well as a normalization of that prostaglandin marker after therapy. So giving us some hints as to a possible therapeutic strategy that you can take based on a biomarker positivity. How are we dealing and what are we doing here at UW with mast cell activation syndrome? So one important point to make here is that mast cell activation syndrome at UW currently is not an automatically schedulable diagnosis. So all the referrals are pre-screened for a clinical history, and then they typically require a set of labs that we need to get usually during a flare, and it's orderable through HealthLink with the mast cell activation syndrome panel. I put a screenshot of the order set here, and you also need to have at least one positive biomarker that in order to merit a visit with our allergy clinics. So this is sort of the algorithm by which we set up through specialty care redesign for this particular diagnosis. This particular model is actually fairly similar to what is being employed at some institutions, including the Mayo Clinic. What do I order when it comes to labs for mast cell activation syndrome? So I typically get the mast cell activation syndrome panel that includes the tryptase and the urine-based biomarkers. I also get a CBC with differential. I also then considered getting a c-KIT mutational analysis. So this is a translocation mutation that you can typically see in many forms of primary mast cell-based disorders. So when you look at systemic mastocytosis, about 80 to 90% of the patients will have a c-KIT mutation having this particular translocation mutation. So you can obtain that using a peripheral sample, or you might need to consider obtaining a tissue or a bone marrow biopsy to get this analysis as well. So not all patients necessarily need this analysis, but some we do need to consider this. What do I not do or not consider? So we do not necessarily want to consider a battery of food or contact allergy testing or food sensitivity panels. Particularly the food sensitivity panels, there's really no validation for this with this particular condition or a lot of other conditions as well. And particularly with food allergies, it unfortunately does lend itself to a lot of false positives. So you want to use your history to clearly corroborate and be more narrow with what you're ordering for food allergy testing or contact allergy testing. I mentioned the bone marrow biopsy earlier, and I'm sure some of our audience members may be hematologists and may be curious about, well, how do we decide when to get a bone marrow biopsy or not? So there was a scoring system that was established about a decade ago and had some validation on a study that looked at about 83 patients with systemic mast cell activation syndrome. And essentially what they did is that they based this REMA score or scoring criteria on about 3 important variables. There's a gender criteria, there's a clinical symptoms criteria, and then there's a tryptase level. Each of these has a subscore associated to this, and then a composite score that you obtain with this. And then based on that composite score, we can decide whether or not a bone marrow biopsy might be needed. So a score of greater than or equal to 2 with this REMA scoring mechanism typically tends to point towards a high probability of clonality in this particular patient, and therefore may warrant a bone marrow biopsy. So an important consideration and a tool to have and think about when this is a consideration for our patients. So let's back up to our case again. So we talked about our patient with multi-organ symptom presentation, characterized as anaphylaxis with a wide range of triggers and responsive to therapy when she's given this in the emergency room as well. So what did we find? So what we found for her was that she had an elevated tryptase of 20.7. All of her urine markers, interestingly, were negative. These were actually obtained on more than one occasion, but they were not positive. She actually had a workup for carcinoid and FEO, which was negative. She had a brain MRI that was done because some of her neurologic symptoms, and that was negative. She, in fact, did undergo a PET CT from skull to thigh, and that was negative for any neuroendocrine tumors. There was a bone marrow biopsy that was also done, and she tested negative for the c-KIT mutation. She did not have any clonality that was noted, nor any abnormal aggregates of mast cells that we typically see in systemic mastocytosis. But she did have some slightly increased interstitial mast cells with a little bit of a spindle morphology that was noted. And overall, the cellularity was normal as well. So what did this then give us? It essentially led us to a diagnosis of idiopathic mast cell activation syndrome. So she does not meet criteria for systemic mastocytosis, but she has partial incomplete criteria that, again, we couldn't put her into just a simple chronic hives or an anaphylaxis spectrum alone. So this diagnosis is the most appropriate based on our existing consensus criteria. So she met criteria A, B, and C. So what about our therapeutic algorithm for mast cell activation syndrome? So our therapeutic algorithm largely sort of overlays the algorithm that we see in chronic urticaria. So at step 1, we typically use antihistamines, both newer generation H1 blockers as well as H2 blockers. We typically up-titrate the dosing anywhere from 1x to a 4x dosing. And then the symptoms that this particular set of medications has the most impact on are the cutaneous symptoms, so skin-based manifestations, and the GI aspect as well. What about step 2? So in step 2, we look at some of those other medications that I had mentioned earlier, leukotriene modifiers, particularly montelukast. We also have cromolyn sodium, which is a mast cell stabilizing agent, oral ketotifen, which is a dual-acting mast cell stabilizing agent and a antihistamine as well, and then aspirin to help with skin-based symptoms, particularly when we have that positive prostaglandin marker, and when you don't have an NSAID allergy that the patient is talking about to us. Leukotriene modifiers, again, as I mentioned, that if you do have that positive leukotriene E4 level, may be important to consider. You certainly can use this, even in the absence of that particular marker. So it doesn't have to be that you have to have that, but it would be an important consideration when you do have it. Cromolyn tends to help a little bit more with GI-based symptoms, so I tend to employ that a little bit more in that situation and scenario. There is a nasal preparation available for cromolyn as well, and that gets employed when there are upper airway symptoms that a patient is presenting. At step 3, we look at Omelism, which is a monoclonal antibody against IgE. Omelism has been around for about 2 decades now. It's approved for both allergic asthma as well as for the past 7 years or so for chronic spontaneous urticaria, and has remarkable efficacy with urticaria and has been a game-changing medication for that condition, which is also a mast cell-based disorder. So it stands to reason that that particular drug is going to do a pretty good job, or is hoping to be able to do a good job for this particular condition as well. So we have used this particular medication in this condition. So there's a number of publications and case series that have indicated potential efficacy for this. But keep in mind that at this point, that is not FDA approved for this particular condition. So, but also keep in mind that some of these patients do have an overlaying diagnosis of chronic spontaneous urticaria as well, because that is how they've sort of navigated their way through the system. So in fact, they have used Omelism as part of treatment for that particular condition itself. Last but not least, I do want to kind of mention that there are tyrosine kinase inhibitors and cytoreductive therapies that we do employ in managing mast cell activation syndrome. However, when I get to this step, I'm often going to be contacting my hematology friends and colleagues to decide when and where would this be an appropriate way to use. I wanted to talk a little bit about Omelism because this medication, as I mentioned, has had a remarkable degree of success with regards to chronic spontaneous urticaria. And so the question was, is this going to have a reasonable, or just as much of an efficacy in other mast cell-based conditions? So this particular publication came out last year. It's a French study, and the design was a prospective survey of 55 patients who had systemic mast cell-based disorders who were treated with Omelism. The dosing was quite variable, and they were allowed to adjust the dosing over the course of the study as well. They had 41 primary mast cell activation syndrome patients, as well as 14 idiopathic mast cell activation syndrome patients as part of this study. And what did they find? So they actually found a pretty good overall response rate for usage of Omelism in mast cell activation syndrome. So an overall response rate of about 78% across the board for all of these patients, with a little bit higher response for the primary group and a little less for the idiopathic group. Another important point to make out of this one was that the median time to response was about 2 months. So a fairly quick onset of response that we start to see. That actually is fairly in line with what we have seen in the literature and in trials with the Omelism in chronic spontaneous urticaria. So we see response, typically within a month or 2 months of starting Xolair or Omelism for that condition. And so this seems to sort of fairly well overlay with what we've seen in the other mast cell-based disorder. However, just because we see a response in 2 months doesn't mean we necessarily stop at that point. So the median time to best response tends to lag behind a little bit. So most often we like to sort of continue therapy for about a 3 to 6 month period at least to gauge whether or not there's a sustained benefit that they're seeing with this. Other important features about the study that I'm not necessarily showing you guys here is that the spectrum of symptom improvement was actually fairly broad. The greatest improvement was noted obviously with the skin-based findings. The systemic symptoms seem to improve. The GI symptoms and pulmonary symptoms seem to improve. Again, that all reflects the fact that Xolair has been used to treat allergic asthma and chronic spontaneous urticaria. So that was an expected sort of response to Xolair. Where it didn't do as good of a job in these patients where some of the neuropsychiatric symptoms and pain symptoms were not as well managed by Xolair. So some points to kind of keep in mind in terms of what is the dominant presentation for our patient can maybe help guide in terms of whether are they going to have a good response to Xolair or not. What other therapeutics are there that we could potentially consider? There is a drug called midostaurin, which is a multi-kinase inhibitor that is currently approved for advanced systemic mastocytosis, but not for all forms of mast cell activation syndrome or idiopathic mast cell activation syndrome. So fairly good response, at least in 1 or 2 trials with midostaurin that we've seen. There are other tyrosine kinase inhibitors that we have used, including imatinib, dasatinib, and masitinib as well. Imatinib, does have some limitations in the sense that you have to have wild-type c-KIT for this to be effective. So in the majority of the primary clonal-based disorders, we do tend to see that c-KIT mutation be present, and they tend to be somewhat resistant to imatinib usage. Dasatinib does work, in that cohort with some degree of success. But again, overall response rate, not as good, so not as widely used. So again, as I said, when I get to this step, I'm usually wanting to talk with hematology to decide whether it would be appropriate or not. What's on the horizon that we can think about, that might be helpful in the future? I listed a few ones here. Siglec-8 is another important molecule that is upcoming and then may have some significance not only in this particular condition, but with other mast cell and eosinophil-based disorders as well. It's an inhibitory receptor found on mast cells and eosinophils, and currently there is an anti-Siglec-8 monoclonal that's being looked at in phase 2 trials, and our hope is that we can sort of see whether or not that would have some implication in stabilizing both mast cells as well as on eosinophilic disorders as well. There is also ligelizumab. This is farther along than Siglec-8, so this is currently in phase 3 trials. Ligelizumab is currently being looked at fairly well for chronic spontaneous urticaria. It is also an anti-IgE molecule, except that it binds IgE with a far greater affinity, so essentially is being looked at as an omelizumab's bigger brother in managing this condition. So far, we've had good results in phase 2 trials, and we're waiting final data from phase 3 for this particular one. There's also this small molecule called fevipiprant, which is a prostaglandin D2 receptor antagonist. Now, this was originally looked at and studied for asthma. However, that particular program has been sort of jettisoned and not currently in use. But the question is, would this particular molecule serve a role or have a niche in mast cell activation syndrome, given that I had mentioned that the most prominent biomarker we see is that elevated prostaglandin marker? So something to kind of think about, and consider, for the future as well. I wanted to share a few other factoids and considerations for mast cell activation syndrome because we get asked some of these questions frequently. So there's been a question about, mast cell activation syndrome and its association with certain forms of Ehlers-Danlos syndrome, particularly the hypermobile phenotype, as well as postural orthostatic tachycardia syndrome. So patients with these conditions often think about, do I have mast cell activation syndrome and do I need to be evaluated for this? So at the present time, the best answer that we can give for this is that there's no mechanistic connection that we've been able to concretely identify and reproducibly demonstrate to say that there is, a clear, relationship there. And therefore, that then translates to our recommendation that a mere presence of those two conditions need not necessarily make us want to evaluate or consider a mast cell evaluation a diagnostic workup. Now, you still need to consider some of those symptoms, independent of that, and then they may have this condition and you will want to consider this, but just the presence of these two need not prompt this evaluation. Keep in mind that unfortunately for both of these conditions, some of the symptoms that they present with, unfortunately, well overlays with what we see in mast cell activation syndrome as well. And that's partly led to some of the confusion in trying to make these associations. I do want to give a little bit of an intro or a word or two about hereditary alpha tryptopenia because this is increasingly being mentioned, in our literature with regards to where do we see this. So this is a newly recognized entity. It has about a 4 to 6% prevalence in the general population and has an autosomal dominant inheritance pattern. Basically, what's going on with this particular condition is that there's a gene duplication or a triplication occurring of the TPSAB1 gene, which is responsible for making tryptase. So you get a gene duplication triplication that then has a gene dose effect, essentially leading to higher levels of tryptase, and then leads to increased amount of symptoms as well. Now that is not consistent, so there are certainly a fair bit of patients as well that don't necessarily present with as much symptoms, but we do want to kind of keep in mind that the symptom pattern presentation and an elevated tryptase may overlay with what we see with mast cell activation syndrome as well. So a new and upcoming entity. Diet, so this is a question that we get asked frequently in our clinic, about, do I need to consider a low histamine diet or an anti-inflammatory diet? And at this point, the best answer that we can give is that at this point, there are no validated, good, randomized placebo-controlled trials to suggest that one particular dietary strategy, is going to offer a clear benefit, for all comers that we see with this particular condition. Having said that, and I will throw a little bit of a disclaimer in that low histamine diet as well as pseudo-allergen-free diet have been looked at in chronic spontaneous urticaria, particularly in Europe, and has been shown to have some success. So when you look at the European guidelines for chronic spontaneous urticaria, they do suggest the possibility of employing that, in the management of that particular condition. So at this point, nobody is recommending that we do this for this one across the board. Now, having said that, I think it's important for us to consider and say that we do want to talk to our patients, and then sort of come up with a patient-specific dietary strategy to be able to allow them to avoid some of these foods, perhaps in a more narrow manner, and then balance that with the nutritional status as well. So we just don't want to suggest a overarching elimination diet strategy. So some take-home points that I want you to take away from this particular talk. It can be mast cell activation can be normal or pathologic. The classification involves sort of a triforked schema with primary, secondary, and idiopathic etiologies with a wide range of symptoms and a differential diagnosis. We do have some expert opinion consensus criteria that is available, but lacks robust validation. So we have to kind of keep in mind that it may lend itself to some degree of over and under diagnosis. There are multiple biomarkers, both urine and serum, that are available, with tryptase being the most specific marker for mast cells. There are therapeutic strategies that are available that largely overlay and enmesh the chronic urticaria therapeutic algorithms to provide benefit to a majority of our patients. And as it stands right now, mast cell activation syndrome has a lot of ambiguity and less absolutes that we can concretely say for this particular condition. So a few other parting thoughts that I want to leave you guys with includes that it is a emerging and evolving diagnosis. So uncertainties are a fair amount with this. All of us in the audience, are likely to be asked or consulted about this condition at some point. So kind of keep that in mind. There's a lot of information that's put out there that may be, taken out of context. So some of our patients are going to be presenting to our clinic with a self-diagnosis of this condition, almost wanting an affirmation or a confirmation from us for this particular condition. So that sometimes, can lead to where there's a mismatch of expectations. Keep in mind that the majority of the literature is based on expert opinion and limited observational retrospective data rather than randomized controlled trials. So as it stands right now, this represents an unmet clinical need for us in our particular field. I do want to take a moment to acknowledge and thank all of our allergy family members here at UW, my faculty colleagues, fellows, nurses, managers, MAs, and schedulers for sort of their tireless work, over all of these years, and particularly over the past 6 to 7 months, as we're sort of navigating our way through our this pandemic. And particularly want to highlight and give a shout out to Dr. Bill Bussey, and Dr. Jarjour, Dr. Denlinger, Dr. Sossman, and Dr. Vogelman, without whom and without all of these people and their support and their mentorship over the years, I would not be here talking to you guys today. So thank you all, and I'd be happy to take some questions, and please stay safe, everyone.
Great. Well, thank you so much for a really wonderful overview of something that I have not been much less familiar with. So I appreciate the information. A number of questions have come up. The first question is, what is the role of mast cells in normal immune response?
So as part of a defense mechanism against, some pathogens, you can see this be exaggerated. So when there's any kind of infection that's going on, particularly parasites, helminths, or venoms, you do see this exaggerated as part of that, trigger as well. So that's typically when you look at, that's what goes on, from a normal standpoint as well. And then again, as I said, some of with the allergic reactions and atopic conditions, you can get an expected sort of a response as well, as part of that process. When it's exaggerated, it becomes more of a pathologic entity.
Is it a problem if we eliminate mast cells in a person? Besides,
so to some extent, it could be, although I'm not so sure that, we've necessarily done it where we've completely knocked them out, and then say what would happen, if I took it out, en masse.
Yeah, or unmasked.
Mm-hmm.
Do we know why patients develop mast cell activation syndrome? Is there a familial pattern of inheritance? Is there any information on, for example, polymorphisms that may be associated with the development? Why does somebody develop it and not somebody else?
So, there's really not a whole lot of data with that one in terms of saying, why do some develop this, versus not. So the hereditary alpha tryptophanemia is the one condition that is, at this point where we are not quite overlaying it on mast cell activation syndrome, that does seem to have some sort of a hereditary pattern associated with it in terms of being transmitted through other family members as well. But with regards to these other entities, it's a bit unclear in terms of why some people do this versus not. We often think of it where you may have had an abnormal response to a particular pathogen or a true allergic reaction, and that sort of throws off the whole homeostatic balance of mast cells, and then there's almost a subsequent immune dysregulation that goes on, and then it seems to sort of take over and continue the process thereafter. So that's sort of some of the theories behind why we see that.
And then a couple of questions about the natural history of mast cell activation syndrome. One is, will it transition into a neoplastic process down the line, or can it be a self-limited process?
So, some forms can. So particularly some of that primary types of mast cell activation syndrome that I mentioned, are associated with a neoplastic entity. So when we do see other cytopenias or cellular derangements, I think we do need to keep that in mind. So some forms, the short answer is yes, they do. And other forms, what ends up happening is that they can stay sort of quiescent, or remain at a stable state for years. When you look at, chronic spontaneous urticaria, and again, a lot of the information that I have is, based, from that condition where we have a lot more information for, is that, there is a sort of a time limitation. A majority of those patients do tend to get better with time, partly because of immune senescence that happens with, age. As you get older, we tend to be a little less responsive, and so therefore a tendency to improve as well. So there's some good news, with aging that you see with it, but then there are also a fair number of patients that sort of plateau and remain that way for many years and possibly decades as well.
Okay, thank you. And then do you want to talk about the timing for obtaining a biomarker panel? Does it need to be in the midst of a flare, or how long do those markers remain elevated after an episode?
Absolutely can. So with regards to tryptase, that marker typically, can elevate within 30 to 60 minutes of a particular reaction and can stay elevated up to 4 to 6 hours as well. So when we're talking about an acute allergic reaction, that's the pattern that we typically see with it. But with mast cell activation syndrome patients, the expectation is that given sort of the propensity of these symptoms to last many hours and possibly days as well before they improve, it is reasonable to obtain them, over an active, symptom flare, so to speak. Now, there are some problems, with this in the sense that, most often patients are being treated with medications concurrently that can impact that testing to some extent. Steroids are often administered. They may be on a leukotriene modifier medication already at baseline. So there is some sort of, where they can be masked to some extent. But if there is a symptom manifestation that is going on, that is active and significant, despite being on those medications, our expectation is that there should be some meaningful rise in these biomarkers during that flare for us to be able to detect. So we often write or put down a standing set of orders in HealthLink for patients to be able to go to either a local lab to obtain this over that time frame, and then they can send it off and we look at them to sort of decide, is there a change with that compared to a prior value or a baseline value.
Okay. So you often get serial values on patients over time to
help there's correct. There's definitely at least 2 or 3 sets that we end up obtaining. It's not necessary that we need to do this with every set. It's initially a question of trying to make sure that we're able to, one, corroborate the diagnosis and be certain that the symptoms that patients are presenting with do in fact correlate with a mast cell based process and not some alternate diagnosis or mechanism that's going on. So once we're fairly clear that that's happened on 1 or 2 occasions, I think then thereafter, it is reasonable to simply assume and use a therapeutic strategy rather than necessarily having to obtain biomarkers at each flare itself.
And then if I'm a primary care provider and a patient comes to me with some of these non-specific symptoms and I'm concerned about mast cell activation syndrome, I get my biomarker panel and it's unremarkable. What do I do next? What should my next steps be?
So, you can certainly do, we've got e-consult mechanisms that are available right now, at least at UW. So certainly a question, to us to sort of say, hey, this is what, a profile that I have. So does this, fit with a diagnosis of mast cell activation syndrome, or perhaps it's the patient that's wanting to be seen with this specialist to decide, is that what's going on versus not. So a lot of times, the answer to that question tends to be a very individualized answer. But in general, when a biomarker assessment has taken place, particularly during a flare, and they have been negative, largely speaking, the sort of pre-test probability for us to find a systemic mast cell activation syndrome disorder is going to be much lower, and our ability to help these patients is going to be lower, on a scale of what we can offer. So therefore, we then sort of say, is there an alternate diagnosis that we ought to be considering versus not? But at the end of the day, if somebody needs to come, hear that from us, then we can certainly accommodate that to some extent.
And then the last question from me, more of a interest question. Why are they called mast cells? Where's the name come from?
So Paul Ehrlich, essentially kind of, called it mast Zellen, and I'm not sure exactly, what kind of the etiology behind that particular one from the 1870s, was. They're obviously, large kind of a granulocyte, cell with thousands of small to medium-sized granules that release their mediator. So not exactly certain about that one.
Okay, something we can look into that. Great. Well, thank you so much for a great overview on a topic that many of us probably don't think as much about, but we probably should be thinking more about, and appreciate the very clear, concise overview of a kind of broad, non-specific etiology.
Exactly.
Yeah. So thank you so much, and look forward to hearing the updates when some of these new therapeutics come online. It'll be exciting.
Absolutely.
All right, take care.
Dr.